So it's Friday, so it's time for Poets. Some of us know that as Push Off Early, tomorrow's Saturday. But in this context, it's the perioperative enhancement team. Inspired by Dr. Sol Aronson and the team at Duke, a selection of clips to get us thinking about the next steps in providing world-class perioperative care. You'll find the full lectures in our back catalogue, or join us at the upcoming perioperative practicum for expert discussions, business case tips, and hands-on workshops. Go to www.edpom.org and look for our international programme of perioperative practicums. Top Bed Talk.
This piece, Is Paternalism Always Bad? Is presented by Monty Mythen with his guest, Mike Grocott, Professor of Anaesthesia and Critical Care Medicine, the University of Southampton. With contributions from Lee Fleisher, Professor of Anesthesiology and Critical Care, the University of Pennsylvania, and Sol Aronson, tenured Professor at Duke University, with Tim Miller, Duke University, and Dr. Attilla Kett, St Peter's University Hospital at New Jersey. Have a listen.
Now, in the UK, we have had for a while now long-term follow-up of our joint replacements, with about 70% capture of all joint replacements in the country, whereby patient-reported outcomes have informed us that although the majority of patients' pain improves, 4 out of 10 patients, their overall quality of life after a knee replacement gets no better, and 3 out of 10, their quality of life gets worse. Now, the orthopaedic surgeon we'd sat down with said that according to his understanding of the US knowledge of long-term follow-up for joint replacements, not a few weeks, but long term, was by his estimate was 1% of surgeons know their long-term follow-ups, which is an interesting, morally and ethically, that's interesting. So can we get the Slido questions up, please? And can we get a microphone to the person over here who has their hand? It's Lee, I think. We'll just get a microphone to you, Lee, if we could. And then we'll come to you, sir. No.
I commend you for saying starting early, because I think consent or the decision for surgery is a temporal decision that really starts with the family. So by the time they see us, at least in the pre-op clinic, is it fair to put the burden from a shared decision-making perspective? And I'm actually curious, we believe in patient autonomy. Have we gone too far, at least in the US, in saying it's the patient's decision? They come to us as experts. How much is paternalism always bad?
I don't think paternalism is bad if the patient is seeking that approach. And patients have a broad spectrum. I mean, you talk about this often, Lee, a broad spectrum of desires for their interaction with their physician. Some people want to be informed and be very clear that they make their own decision. And some people, and I see this a lot in critical care, they really don't want to know all the details. They just, what would you do, doc? What would you do if it was your mum or your dad or your child? And all those, wherever you sit on that spectrum, that's fine. And clearly we have more of a role and a different type of responsibility at this end of the spectrum. But I think if the patient desires the autonomy, they have the right to not have whatever they want. They're coming to us. We have no right to tell them what to do. We have an obligation to advise them and help inform them to the best decision in the context of their life.
Another interesting perspective, and I think one that's probably more likely to resonate with us in the States right now. We're not single payer. We're not the NHS for sure, at least not in the foreseeable future. Is interestingly what we've experienced is sometimes the surgeon really appreciates some other entity to help them say no. In other words, the burden on a surgeon to operate when there is a recommendation, albeit from the patient or the primary care who thinks that's the pathway to take, they're in a tough spot to say no. It's probably not in your best interest. And so what we've developed at Duke, and it's been really interesting in almost a underappreciated way, is we have a clinic that serves the particular special needs of an elderly population, the POSH clinic. And I would say about 2 to 4% of the patients that they evaluate, these complex elderly, cognitively declined kinds of patients, are actually, after consultation with the family and other extenders in that concentric circle of their world, they help drive the decision that surgery is not in the best interest, and it takes the burden off of the surgeon to have to be the one to say, no, I don't think this is, in your right, best interest. I just want to make that point and hear your comments on that. And the second comment is that, again, because we're not a single payer, I think in our bundled-based world, our sort of externally driven pressures that are economically upon us, that decision to say no will be made because we can't afford to make the wrong decision. I think there's going to be an economic drive to that.
So I'm going to answer both questions by actually talking about our cardiopulmonary exercise testing service, which is not a lateral move. They're very closely related. So that is our means of, or a central component of our means of stratifying risk. And when I moved to Southampton, we went on a journey of implementing through some patients to now almost all patients having major surgery. And it was striking in the some patient stage that a large number of those patients that the surgeons were at that time referring, it's now routine, they were doing exactly as you suggest. So the patients where they just didn't feel very comfortable and they wanted a reason not to, but they did have the particular pathology that needed the surgery, and they were very much, and they would admit this, they were sending them to us in order to have a get out. So I think that's absolutely correct. That's the second part of what you said was
the external force of economic tension to drive that behavior.
So the NHS does not currently function fully as an ACO. It's on the bundled payments spectrum. So we have commissioners who buy care off institutions, and the institution's an independent financial entity. With the cardiopulmonary exercise testing service, we have a shared decision-making model, and one of the things that was overwhelming in the business case was not the more typical things that cardiopulmonary exercise testing is named for in terms of stratification to critical care. It was the fact that we were, for some of our major surgeries, getting a 10 to 15% shared decision not to operate. The shared decision related to the patients, as I described in the presentation, who were at the highest risk. They were making a rational decision based on harm outweighing benefit. They're the ones that are going to have the complications and the long stay, and therefore be a resource strain on the institution. So that the business case was made on the shared decision-making element of cardiopulmonary exercise testing. So I think the economics work.
Mike, just to clarify, in the shared decision-making process, because I remember when I was a young doctor in any system that patients would be told they weren't fit for surgery, for example. The shared decision-making process is different from the point of view as it lays out the risk of the individual. And if they decide to go ahead with the surgery, despite there being an extremely high chance of death or a poor outcome, they still have the right to pursue that path if it's informed. In other words, if they turn around and say, I understand I've got a 30% chance of dying, but I cannot tolerate this thing, and I want it to try and be dealt with. I understand, doc, that I might not get off the ventilator. That's okay.
That's okay.
But that's fully informed.
As long as the surgeon is happy to go with that.
And everyone's involved is fully informed. Yeah. Did you want to come back on that, Saul?
Just another interesting anecdote. We just recently looked at our data from the CJR, the joint replacement program that was in place until Tom Price and the administration currently kind of discontinued that program. Interestingly, around 8,000 patients that we looked at CGR versus non-CGR hospitals, we looked at bundle busters, if you will, those patients that we were able to do with some margin by virtue of our care redesign, and those patients that we lost money on. Despite our best intent to identify the risk and manage that. And one of the interesting things that we found is that the likelihood, that one of the greatest predictors of the likelihood for a readmission within a 90-day window was whether or not the patient was married or not. Now, that's a surrogate for home care, if you will. So the question then is, should we, this is a rhetoric question, if we're under the pressure of economic sustainability, not be inclined to do a procedure if we think we're going to not be sustainable by doing it unless we know that we can get somebody to a patient's home and visit them every Tuesday or whatever if they're not married? It's an interesting question, but it changes it's an economic variable of what is a right patient for the right surgery or wrong patient for the wrong surgery.
So short answer, no. But I mean, it's a very intriguing question. It plays to the So the prehabilitation agenda and the notion of rationing, which, if you don't do your exercise or if you don't give up smoking, will we withhold surgery? That's not actually what's going on in the UK, but there is a considerable amount of transactional behaviour between doctor and patients where they say, look, if we pause the clock here and you do give up smoking, it will go better. So how about do you want to do that or do you not want to do that? Which is very different from we're going to ration. Now, it's a little bit difficult to stop the clock and get people to get married, so I'm not quite sure where we're going to go with that. But I think individuals who we know are going to have a challenging post-operative recovery, and including post-hospital recovery because of their social circumstances, then we probably need to set up the social support. If we're going to be fully frank and honest, we probably need to share that with them as part of the discussion about risks of surgery, risk of readmission.
So before I come to the next question, and maybe this needs to go back to Sol for a second, one of the challenges with informed decision-making is if you look at the literature, as I said, there's a reasonable chance that you'll be doing 10 to 15% fewer surgeries on that cohort of patients who go through it based on their own fully informed choice. So if you're in the business of doing surgery, you've just knocked your productivity by 15%. So who's going to fund doing the right thing?
Just jump out. You may not have knocked your productivity. You may not
your overall, you expressed wrong.
You may improve your productivity.
Depending on the funding system. If you're fee for service, then business is business. If you're bundled, then it's a different equation. So where's that come from, Sol? How do you?
It's a great point, and I think it really underscores the whole philosophic foundation of this discussion, which is we're in a transition point in our healthcare system in this country, for sure. Maybe defined a little bit upstream to what you've already experienced in the UK. But we have to behave differently as we drive toward population health science. And so the question of what was the definition of value yesterday is going to be answered very differently tomorrow. And so more surgery may not enhance value.
I mean, there are a number of, as an institution, you manage your medical legal risks much better if you don't do surgery on people where harm outweighs benefit.
And a bad choice of words, Mike, because productivity actually goes up, doesn't it? Because throughput is better. And, Tim?
I think it's very interesting when you think about this question overall to look at what we do. And there's a very interesting book, How Doctors Die, that basically says that when we're looking after ourselves or our loved ones, we have a very different approach to often a lot of patients, and we're much less aggressive, particularly in long intensive care stays, being in hospital in general. And I think we're the ultimate informed patients, and I think we would have very different approaches to our 85-year-old mother who may need a Whipple, and we're much more likely to realise that after a Whipple the life expectancy is only 9 months, and that may be the wrong thing to do. Do you know if anyone has looked at that? Because that's an interesting model for the ultimate shared decision-making.
So, I mean, the literature you cite is consistent. So if you ask oncologists about cancer care, they are much more conservative in regard of their own health than they would be in regard of their patient's health. So given the same scenario, they're more likely to recommend a particular type of chemotherapy, for example, for their patients. In a way, that's the fundamental message to all of this, because as providers, it's easy to feel a bit paternalistic. But if you just flip it around and go, so what if it was me, what would I want? I would want all the information and a very good explanation and maybe a second opinion, because I don't want to make what's going to be a very, very important decision in my life. I don't want to make a wrong decision. And that's what we should be offering to our patients.
Attilla Kett, I'm from New Jersey, anesthesiologist, and my question relates to time. That when it's a shared decision making, you need to have an empowered patient who is obviously very educated before, and physicians have a very significant time constraint in their hand. My question is, where do you see the role of perhaps technology? We use intensively technology to educate these patients. Perhaps also some type of visual help aid in the decision making, so they already separated the two things, educated, and when they make the decision. In the meantime, perhaps another important part of it is not just the patient, it's the patient's family, so they have a chance to discuss it. I'm wondering where do you feel that?
So I think that you are undoubtedly correct that you can help for some patients, you can help that decision making by providing sophisticated decision support, and that would, like I'm sure for anybody in this room, that would work really well. And you can pore over the graphs and the figures, and that will inform your decision. For a substantial proportion of patients, for a variety of different reasons, that they might choose not to engage with the world in that way, or they might be unable to. That's not the answer, and actually the fundamental core of it, I think, is the conversation, because the conversation has to establish where they sit on the spectrum. Do they want to decide, or do they want you to decide? And then the communication. I mean, there's a reasonable amount of technical literature about how to do shared decision making, so the communication of harms and benefits in the same way and in a way that is understandable. So not risk ratios or odds ratios, but how many people, 3 in 100, 3 in 10, one person in a village, one person in a town, and commuting everything the same way. And even, say, positive risks, negative risks, 5% of people survive as opposed to 5 people die, is received differently. And if you present the harms in one way and the benefits in another, people are, even we, when are unable to weigh those things correctly. So a lot of it is about very precise but simple communication of risk in a consistent manner between both benefit and harm.
Top Med Talk.
Nick Majerison here. Thank you for listening to Top Med Talk. Now, make sure you've subscribed to Top Med Talk on your podcatcher or however it is that you're listening to us at the moment. And you're spoilt for choice. We're on pretty much every single podcast platform you could think of. So make sure you've subscribed. Make sure you've engaged with us on social media, Twitter, Facebook, LinkedIn, YouTube. And make sure you've signed up for our email updates on topmedtalk.com. If you get yourself there, you'll find a website that contains all of the podcasts that we've ever done, and it gives you the chance to sign up for our email updates. That way we can always get in touch with you and tell you what we're up to. Oh, and while you're online, check out ebpom.org/meetings. While you're there, get excited about EBPOM London 2019, the London Perioperative Medicine Congress. It's on July the 2nd, and it's one of many meetings that EBPOM organises around the world in order to communicate the perioperative medicine message. Have a look, ebpom.org/meetings.